Now, Brian, it's good that you've given up your time now to come with us tonight and explain your journey. You're known to the CLL community in Ireland because you made the travel over here and you spoke at some of our information days. You're a long time patient and you do have an amazing story to tell. Our patient community did hear you speak at CLL Ireland events in the past, but for those who maybe are in on this webinar, who are maybe hearing you for the first time, can you tell us a little bit about the early years of your diagnosis? How did you navigate treatment options?
Sure. And first, I want to thank CLL Ireland and CLL Support UK for inviting me to speak, and for the efforts that I think you two charities have done in terms of helping the CLL community be aware of what the treatment options are, to educate and support and advocate for their best care. And we really are all in this together so we can learn from each other. So I was diagnosed with CLL in 2005. And as for people new to the diagnosis, they should recognize that the treatment options back then, 16 years ago, were pretty thin. There weren't really any treatments at that time that were proven to prolong life, let alone cure the disease. There was things that could knock the disease back, but they didn't make you live any longer. So and as we also know, and this will be an important point, is that everybody's CLL is heterogeneous. We say at the CLL Society, if you know one patient with CLL, you know one patient with CLL, because everybody's flavor of CLL is different. And I had rather an aggressive form of CLL that had a rare complication, what's called an autoimmune complication, where I kill off my own platelets, ITP, or immune thrombocytopenic purpura. So I had multiple hospitalizations and had a very difficult course. I went on to have a bone marrow transplant, what's called a hemopoietic stem cell transplant, which didn't work for me. And I realized I was running low on options. My type of CLL had mutations that I think Dr. Munir will be talking about a little more in detail, that made it unlikely, very unlikely, to respond to chemotherapy. So I was keen to jump and look at new options, and it's a lot about timing, and my timing was good in that I was able to jump into a phase 1 trial, one of the first 100 or so people in the world to try a drug that didn't even have a name then. It just had letters, PCI 32765. Which later became ibrutinib, which has revolutionized the care and treatment of CLL. While I was doing this, I started to blog about what was going on with me. I started to leverage my position as a family doctor and was attending the major hematology meetings. We started to do research and present that at the major hematology meetings. So I had a bit of a following at this time through my blog. And then we set up the nonprofit to tell the story, the CLL Society, which was to meet the unmet needs of the CLL community. And there are plenty of them in terms of education and advocacy and support and research. And so I've always said, if you're advocating for yourself, you're advocating for others. If you're advocating for others, you're advocating for yourself. So there's not a strong division between those. I went on and I was lucky to get almost 7 years out of the ibrutinib, what later became ibrutinib, in that clinical trial, and then I relapsed. And then I've always been an early adopter of therapy, so I jumped into another novel phase 1 trial of a drug that again didn't have a name at that time, JCAR014, which later gave birth to Liza-cel, which is a form of CAR T, chimeric antigen receptor T cell therapy, which is a therapy that where they take your T cells out and reprogram them, genetically reprogram them using a lentivirus, a virus that's distantly related to the HIV virus, to teach it to recognize and attack the cancerous B cells. And it was a very difficult time for me, but it was extremely successful. That was 3 3 years ago, and I remain in a deep remission. And I've been telling that story and working hard to get all these new therapies, these targeted therapies that attack the CLL where it lives, where it's addicted, and the cellular therapies for the more difficult cases. So that's my story briefly, but I'm happy to fill in more details or talk more about that. Yeah.
Brian, if I could ask you about the CAR T, that if, you know, in the last few years, we've had all these other agents that have come on, like the Loxo 305 and these other inhibitors, that if they were around at the time, would you have gone for CAR T? Or would you maybe have considered maybe another inhibitor?
So excellent question. And this has to do with how do you make decisions? And I think you need to be informed about decisions. And I think one of the harsh realities, and this sounds terrible when I say it, but let me explain it, is as a CLL patient, you have to look at all treatments as being palliative. In other words, they're not curative. So whatever you're going to do is going to kick the can down the road. And if you have a more indolent, slow-growing form of CLL, it might kick the can down the road for 15 or 20 years, which is great. So almost like a functional cure. You may not be cured. There still may be some CLL, but what do you care? You take a pill, you're okay. Or you do a year of treatment and you get a 10-year glide out of it. What do you care? You know, if the CLL comes back in a dozen years. But with my more aggressive form, I was a little concerned about that in that if I went on something else, because my cancer had already mutated around a number of different therapies, I thought the likelihood of me getting a durable duration from anything new that picked off one of the pathways in CLL, no matter how cleverly it did it, was unlikely to be durable. And then I'd be looking at CAR T, and I'd be looking at CAR T a few years down the line. And there's always a question, would the CAR T be available? What would my health be? I'm pretty healthy now, but 2 or 3 years later, could I have developed another issue that could have prohibited it? So sometimes the window's open and you got to jump through when those windows are open because they might close in 6 months from now. So that was my decision, but that decision is going to be different for everyone because I had more of an aggressive form of CLL, and I really wanted to give it a big kick, and just not have to deal with it for a while.
I'm always thinking, Brian, when we trying to kick CLL right down into a deep remission, minimal residual disease that we'll hear Tal maybe talking about later on. But I always like the testing. Like a few years ago when they used to test the cells, and it might have been 1 in 1,000, but now they're able to test the cell in 1 in 1,000,000. Could you explain what that test is, maybe?
Sure. So one of the important factors, especially as we're now this isn't such an important factor with drugs like ibrutinib or acalabrutinib and some other therapies. But with chemoimmunotherapy like FCR, fludarabine, cyclophosphamide, and rituximab, and with venetoclax-based therapies, Venclexa, one of the parameters of how well you're doing is not just whether you've gone into remission and your nodes have shrunk, but how deep that remission is. And one way to measure that, the old way is the doctor looked under a microscope and saw if there was any cancer cells. Well, that was helpful, but it wasn't that deep of a remission. Then they developed a test where they could look at the fingerprint on the cells. It was called flow cytometry, and that could pick out one cancer cell in 10,000. There's other tests where they modify the DNA called polymerase chain reaction, but the new breakthrough is this gene sequencing, that when the cancer is active, they look for signatures in the DNA of the cancer that aren't found in any normal cells. And then they can look for those again in millions and millions of cells later, and those can be accurate down to 1 in 1,000,000 cells. Now, every test has a level of detection. So is it possible that if you're negative at 1 in 1,000,000, you have 1 in 10 million cells? Absolutely. We have trillions of cells in our body. So, unless you can get down to look at absolutely every cell, which is never going to happen. So it doesn't mean that you're cured. It just means that it's down to such a low level that the likelihood of it coming back quickly is very slim. So And there's now research going on suggesting, and Dr. Munir will talk about this more, that using MRD might be a more helpful guide. We know, for example, with venetoclax and with chemoimmunotherapy, the patients who reach this undetectable level of measurable residual disease or minimal residual disease tend to have deeper and longer remissions. Just kind of makes sense. And this may be a shift in how we measure our CLL. So we're encouraging people to push in their countries to have MRD as part of the clinical workup of patients where appropriate.
And I know that not so much a question, but just a point to make is that I know that there are a lot of countries, and even in European countries, that don't have access to them tests, but kind of leave patients maybe blind. But that's something that we can work on. I suppose moving on, Brian, that like little did we know as a community that's already immune compromised, that the CLL community will be dealing, and you know what I'm going to say, the global pandemic. That like, how are you managing the risk of COVID? What has it meant for you? I suppose as a patient advocate that I know very well and has traveled all over the world to talk, to advocate, to get other patients to advocate. Like, how are you managing the risk of COVID throughout the pandemic and now going forward?
Well, I think the first and most obvious thing is that I'm here on Zoom and I'm not enjoying visiting a pub with you and Jan and being able to see your children and visit my old friends like Dr. Munir and others. I just you know, I'm off the road, and that's a mixed blessing. I mean, it's nice not to travel so much, but honestly, I love traveling and I love meeting with people. And there's the scuttlebutt at these conferences where you learn things. People kind of whisper that, did you know this trial, or this is going on, or this isn't working out, that you don't get. So I sincerely miss that. And I think what we've realized is that it's how much a cancer of the immune system we have. Other people have come to recognize, I mean, one of the silver linings is we live this in this world. If somebody coughed or sneezed, we would cross the street and not walk by them. I've been wearing an N95 mask on a plane for 10 years now. So I was already doing all of these things, and a lot of us were much more careful about hand washing and things like that. And the rest of the world has learned how we live. But my big concern right now, and this is really a difficult topic to discuss, and you're going to go over the Birmingham data, and there's data out of Israel, and there's more and more data, and LLS will be releasing their data soon, which is not going to contradict what we've already heard, is that our response to the vaccine is less than optimal. So we have to live in a world, even if we've been vaccinated, as if we weren't vaccinated. So, and the big concern is, don't leave us behind. I don't know what the numbers are in the Ireland or the United Kingdom, but it's approximately 3% of the population is immunocompromised. So in the US, that's 10 million plus people. And that's not just CLL patients, that's people with HIV, people on steroids for their arthritis and things like that. These people don't respond to the vaccines and are still extraordinarily vulnerable. So don't leave us behind. We're the first in line to get the vaccines, but they're not working for us. And there are possibilities with monoclonal antibodies, perhaps with boosters, with better therapeutics that might be helpful for us. But don't forget about us in this rush back to normalcy, because we don't want to be left out of this. I mean, I want to visit Dublin again. I want to visit London again, you know, and it's not just that. I want to be able to hug my grandkids when they're back in kindergarten. The biggest question I get asked is, when can I hug my grandkids again? That is the recurrent question that we get asked. And so personally, I think we have to make decisions. If you want not to get COVID, stay locked down, have your groceries, your pharmacies, everything delivered. Don't go out. You will not get COVID, I guarantee. Maybe you can go out for a walk in a park, stay 6 feet away from people. You won't get COVID. But then what can you start to do to have some risk? So, you know, at one end is you're not going to go to a mosh pit or a huge concert with thousands of people not wearing masks. But there's all kinds of things in between. And there's kind of, you know, green and yellow and amber and green, red lights that you can be looking at. Where do you fit in that? I've tended to be on the side of staying locked down, to be honest. That's been my personal choice, because I think things are coming with the monoclonal antibodies that can protect us. But other people are wanting to take more risks, and we can talk about how to manage that. But I think certain things you want to stay away from: crowds, travel on public transit, planes still give me a little pause. Eating at a restaurant indoors gives me pause. But if you said, I want to eat outdoors and have a coffee with friends that are vaccinated and I'm vaccinated, I'd say, okay, is that completely safe? No, it's not a question of safe. It's a question of safer, you know, and where do you want to be on that spectrum? That's how I look at it.
I suppose maybe I'll just make another point is that what I've witnessed is the difficulty I've seen it in the UK and seen it in Ireland, that when advice is coming from government and from health authorities, and they're saying it's okay for two people to hug each other and all, but they're not adding that this immune compromised, the 3% of the population that are immune compromised. So the information can get a bit confusing. And I suppose, Brian, that kind of leads me to another question, is the importance of self-advocacy for patients. And what advice would you give patients and their families about maybe getting involved in local organisations like CLL Support in the UK and CLL Ireland? And what can be achieved through these organisations, you know?
Such an important question. And I think your point is right. The government messages, have to be, keep it simple. And, so they often leave out the immunocompromised. So understand, when they're talking about vaccinated people, they're not talking about us, sadly. And there may be subtleties in that. And hopefully we'll have time to get into some of those subtleties. If you've been tested for antibodies and other things, that's complicated. Also understand that even though we're the most common cancer in adults in Europe and North America, we are still an orphan disease, and most internists, family doctors, general practitioners, and even hematologists don't see a lot of CLL. So they're not on top of their game, and they don't know what's going on, and they may not know about our immunocompromise. So we have to be our own advocates in that regard. And the way we advocate best is as a group and say, well, here's the stance that CLL Ireland has taken on vaccinations. Here's the stance that CLL Ireland has taken on getting approval of these drugs for use. Here's the stance CLL Ireland has taken on clinical trials. Here's the stance that CLL Support SA has taken on sheltering, shielding. So that, and there's papers and positions, and we can work together in that regard, and you also can be best informed. And I will tell you that, Michael and myself and all the European organizations through CLAN, we all share tons of information. So we have all of that. It's all free. It's all accessible. We're all in this together. We're all there to support each other. But to know that the other piece of this that I just have to get across is that there are things that a fellow patient or a fellow caregiver can tell you that another patient could never understand, that only another patient could get it across to you. That your doctor, no matter how compassionate and caring he or she is, they're pushed for time. They've never been in that situation. Somebody can explain, I remember what it was like when that IV first entered my arm. I remember what it was like when I got that shock of that diagnosis. I wasn't expecting it. I was going in for something else, and I was told that my blood count was abnormal. Somebody else can walk you through that. And to meet people, like Jan or me, who've had this for a long, long time, and see how well we're doing, that's a message that another doctor can't really give you. So I think it's really important to be connected with other patients. There's things you can only get from another patient and another caregiver, and the best way to do that is through an organized charity or nonprofit.
Yeah, well, I suppose that we witnessed that in CLL Ireland when we worked on a venetoclax and a obinutuzumab submission, is that when the patients actually, we all worked together, the submission, just, there was strength going into that submission. And it's probably the first time that our health service executive will actually get a picture of what it's like to live as a CLL patient in Ireland. I don't know, is there anything else, Brian, that you would like to add?
No, I think the most important thing to say is that these are difficult times, but I ask everyone to be patient. And there's been incredible progress made in terms of CLL. If you look at any of the data on CLL, it's all looking backwards, and some of it's pretty dismal. But if what the almost to a man or woman, if you talk to CLL experts these days, they say they're not losing patients to CLL. They're losing patients to the complications of CLL, like infections and second cancers and transformation. And we can talk about that. But CLL is becoming a nuisance, an annoyance, a project that you have to deal with it. But it's not necessarily going to shorten your life, and in most cases it won't. The other thing I would say is with the COVID, I beg people to be patient, because there's things that are coming that are very excited. Personally, I'm very excited about the monoclonal antibodies. We should have data. I wish it was yesterday. It's probably 3 to 6 months away, that are going to show that the monoclonal antibodies, this is a passive form of immunity where we're given the antibodies of people like from Wuhan who fought off the infection well. We're given those, and those should provide very high levels of protection. They certainly do in the immunocompetent, and there's no reason to believe they won't for us. So there's a lot of reasons to be optimistic, but we still have to hold on and be careful for a little bit longer. So, I say stay strong. We're all in this together. And if I can be helped through the CLL Society, or reach out to CLL Support, or reach out to CLL Ireland, we're all there to help you.